Thank you for joining us for Governor Mills' monthly webinar leading up to our 2023 summit. And I'm going to give you 30 seconds to get into the Zoom and get adjusted, and then I'll be right back with you. And thank you so much for giving us your time this morning. Okay, I think we will get started. I'm really pleased today to be able to introduce our presenters today on this the issue of SUD treatment in our hospitals. We are very fortunate to have these two expert clinicians with us. I also want to introduce Madison Barasser, our SUD program person at the Office of Behavioral Health, who works with us in these webinars. And of course, I want to thank AdCare for their logistical support. I'm Gordon Smith, the state's Director of Opioid Response. And I just make a couple of preliminary announcements before introducing Dr. O'Connor and Dr. Solotaroff. We will have another webinar. Our next webinar will be on Friday, the first Friday, as usual, on May 5th. We haven't announced the topic of that program. There are so many things to talk about as we continue our efforts in Maine to respond to the crisis. And so watch for those announcements. We're also able, for the first time today, to announce the date and the location of the governor's 5th annual Opioid Response Summit. It will be on Thursday, July 20th at the Cross Insurance Arena in Portland, with breakout sessions being held at the Maine Health Conference Center next door, as well as at the Holiday Inn by the Bay across the street. And there may be additional venues in terms of our breakout sessions. So we look forward to seeing many of you in Portland on July 20th. We will be announcing keynote speakers and breakout sessions over the coming weeks. So again, I now, also logistically, if you have questions today, if you would be good enough to put them in the question and answer box, not the chat, put them in the question and answer box. Some of them will respond to immediately as Madison and I are here. Others we will hold for the until the two speakers get through the PowerPoint. I'm going to introduce both of them at the same time, and then the PowerPoint will flow accordingly. Many of you know Alane O'Connor, our doctorate of nursing practice. She has more than 15 years of experience in addiction medicine in a variety of settings, including both inpatient and outpatient. She's the director of the perinatal addiction medicine at Maine Medical Center. She's the medical advisor of our Maine Mom initiative at Maine Care. She voluntarily co-chairs with Dr. Letourneau our outstanding clinical advisory committee that meets every other month to provide our efforts with good sound clinical advice and policies, of which one of these policies is what we're talking about today in this webinar. She also leads the Somerset County jail project, buprenorphine pilot, which is piloting the exclusive use of Sublocade, the extended release buprenorphine product. She's lectured for years, regionally, nationally, has published extensively, and helped train more than 100 resident physicians. I can remember hearing her 15 years ago at Sugarloaf, and I'm so delighted that I've been listening to her ever since, and we're really happy to have her with us today and all the work that she does in this area. New to many of you is Rachel Solotaroff, who's the Executive Clinical Director of SUD Services at Penobscot Community Healthcare, where she provides patient care and oversees substance use disorder care, delivery in the outpatient setting, provides medical direction for withdrawal management as well. Prior to moving to Maine, Rachel served as the CMO and the CEO at Central City Concern in the other Portland, Oregon. And that was an organization that provides healthcare and supportive housing, supportive employment to people experiencing homelessness. It is a well-known program that even warranted Rachel's mentioned in Sam Canonas's latest book, The Least of Us. She's a general internist with addiction board certification in addiction medicine. She also holds a master's degree in clinical research. Really appreciate the two of them joining us on this presentation. And I believe Dr. Solotaroff, you're going to lead off.
Great, thank you. Thanks, Gordon, for having me here, and Alane for having me collaborate. And Madison, are you driving the slides?
I think Lorena is.
Oh, Lorena is great. Okay, awesome. So we'll be talking, this is under the aegis of Gordon as the Director of Opioid Response, and we can advance to the next slide. And today, Alane and I will be talking to you about how to promote medications for opioid use disorder in hospital settings, which is some research and a set of guidelines recently released by Maine's Opioid Response Clinical Advisory Committee. And I'll just start out today by giving you all some framing evidence, some context to sort of set up the need for these guidelines, as well as a few patient cases, real patient cases that bring this a little bit closer to home. Okay, next slide. So it comes as no surprise, I'm sure, to this audience that here in Maine and in the United States, we continue to see really now an epidemic of drug overdose deaths. And this epidemic is fueled largely by really a poisoning of the drug supply, poisoning by highly lethal illicit fentanyl, but also contaminants such as a medication called xylazine you may have heard of, as well as other potent chemicals. And while we'll focus on opioid use disorder specifically today, it is worth noting that this is also a polysubstance crisis. We're seeing overdose deaths related to cocaine and methamphetamine as well. So what this all means is that in 2021 nationally, this staggering statistic may be familiar to you, over 107,000 people died from a drug overdose. Now, just to put that in context, that's a higher mortality rate than we ever saw at the peak of the HIV epidemic or in motor vehicle accident fatalities. It's also worth noting that this death rate is growing fastest among Black and African Americans, especially men. And here in Maine, unfortunately, we're not spared this tragic rise in deaths. Our data from 2022 show a 13.5% increase in overdose deaths from 2021 at 716. And this is a curve which is climbing. And unfortunately, we've not yet seen its peak. Next slide. So we're focusing on opioid use disorder today. Why specifically focus on hospitals? Well, unfortunately, people with a substance use disorder in the hospital are a particularly high risk cohort for death and morbidity. A colleague recently sent me a quote from a researcher saying over this idea of overdose death as a hospital acquired condition. You may or may not know that 1 in 9 patients, almost 11% of people in the hospital have a substance use disorder, and most often it's not being treated or even recognized. So often these folks are being admitted to the hospital for conditions related to an opioid use disorder, for infections like an osteomyelitis or endocarditis. And not treating them for that substance use disorder really is analogous to somebody with diabetes being admitted for a diabetes-related infection, and we treat the infection, but we don't give that person insulin. We also know that individuals who are seeking care at hospitals are overall at increased risk of drug overdose death. Again, this idea of overdose death as a hospital-acquired condition. Here in Maine, almost 1 in 5, 17%, from our recent data of Maine of decedents from a fatal overdose were seen in the hospital or in the emergency department 30 days prior. In Oregon, I spent about 20 years there, so I'll have some Oregon data for you today. A team looked at a Medicaid population with opioid use disorder who were admitted to the hospital, and 7.8% of them died within a year after discharge. So that's all-cause mortality, both overdose and non-drug related causes. But that's a mortality risk about equal to death after 1 year when you're hospitalized for an acute myocardial infarction. So really the idea here being that we're focusing on hospitals because hospitalized patients with opioid use disorder are at high risk overall. Next slide. So the good news here, though, is that this may be a very high-risk population, but it is also a prime opportunity to intervene, and we have really good data and methodologies by which we can intervene. So first and foremost, it's worth knowing, and this is for any opioid use disorder, person with opioid use disorder, not just hospitalized patients, but medications for opioid use disorder are the single indispensable tool that we have to prevent overdose death. And this was shown really powerfully by a study by Sarah Wakeman and her team down at Mass General, where they looked at 41,000 claims of people who had been diagnosed with an opioid use disorder and looked at their mortality and their utilization of services in 3 months after diagnosis. And they looked at all these different interventions, whether it was residential treatment or withdrawal management or intensive outpatient, whatever it may be. And the only intervention that was shown to decrease mortality and acute care hospitalization were specifically buprenorphine and methadone, medications for opioid use disorder. And the risk reduction was powerful. It was a 60% risk reduction in mortality. Another study by Gail D'Onofrio down at Yale from several years ago looked at the initiation of buprenorphine in the emergency department and compared what happens when you initiate medication in the ED versus just give somebody a referral and treatment, kind of the SBIRT model. And it was shown that patients who were treated in the ED were less likely to use illicit drugs and more than twice as likely to still be engaged in medication treatment 30 days after follow-up. And finally, another study from Mass General looked at patients, this was a retrospective cohort study, looked at patients admitted over a 5-year period with opioid use disorder and found that those who were on medication on admission had 30-day and 90-day significant reductions in 30 and 90-day hospital readmission rates. So those are some of the follow-ups. I'll give you a little more information about other benefits related to SUD care in the hospital momentarily. Next slide. But first, I want to focus in a bit for those of you who work in the hospital setting. What can happen sort of in the hospital experience, not just for patients, but also for the hospital team, for providers, for nurses, for other people working on the floor, for the security team? What are some of the harms that can be incurred when we're not caring for opioid use disorder in the hospital setting? One is that patients may be in opioid withdrawal, and those withdrawal symptoms will go untreated, which is enormously uncomfortable. Patients may also have untreated pain. And I'm going to refer here to a really interesting qualitative study that was also done in Oregon, where they looked at whole care team experiences before and after the implementation of an addictions consult service. And here's a quote from one of the providers specifically about these first 2 bullets. She said, if patients were withdrawing, this was before she had support from an addictions team, we had this perception that, quote unquote, you can't do anything about it. We had this perception that the federal law said you weren't allowed to start them on methadone or buprenorphine in the hospital. We had this perception that giving them opiates was kind of unethical because they don't actually have a pain problem and that you were just treating their addiction. And that was the prior approach. So these untreated symptoms can lead to patient-directed discharges. And this can really, again, from this same study, they noted this can really cause moral distress, certainly for patients, but also for the staff. This idea that our care is of variable quality, and even the care I'm giving overall is futile. One provider said, I felt like I was on my own to manage opioid use disorder, so sometimes I just wouldn't do it. Patients would then have a self-directed discharge, and I would feel like I hadn't even done my job treating their other medical conditions, like congestive heart failure. This untreated substance use disorder can lead to really chaotic or reactive interactions with patients for staff. And this can lead to negative feelings for staff as well as patients, as trying to manage untreated addiction causes. We instead resort to increased restrictions on behaviors. That leads to escalating behaviors and this sense of no standards of how to care for or support these people. One provider said, it feels reckless and risky. Oh, next slide. Thanks. Okay, so on to the good news, which is that this idea of what we can do in the hospital, I love this framing. A colleague of mine said that it really can be a reachable moment for patients, but also for our staff. So a quick rundown, some more of the literature of the benefits of treating SUD in the hospital. One study from 2021 showed this improved trust in providers by patients and also improved a provider's feeling of satisfaction. From the provider perspective, they noted several themes: that their care was increasingly humanized, they felt greater expertise in providing addiction care, there was greater reliability and consistency in care, and this feeling of satisfaction from granting agency and choice to patients, mitigating those power struggles that hospitalized patients with SUD frequently experience. Then from the patient experience side, an interesting survey study really focused on this idea of hospitalization as a reachable moment for patients themselves. Many patients noted that it felt like a wake-up call, where this acuity of the hospitalization, the sense of mortality, really became motivation for change, and that the hospital experience disrupted their substance use. Specifically, I loved this. The patients, really valued and trusted providers who understood substance use disorder, who understood treatment choice. But 3 other things patients noticed when they were cared for, when their SUD was cared for in the hospital setting. They said how they loved having peer support, peer recovery mentors in the hospital, how important that was, having access to medication for opioid use disorder, and also really appreciating coordinated care post-discharge. Hospital SUD care also can increase adoption of evidence-based treatment, and Alane will talk about this in her remarks about ways we can really bake evidence-based practice into the hospital setting. There's evidence that shows engagement in post-discharge SUD treatment. So treatment for SUD in the community is a national gap in and of itself, and intervention in the hospital can help to close that gap. Another interesting study from Mass General showed a reduction in SUD severity. This was a multidisciplinary addiction consult team that gave pharmacotherapy, but also motivational counseling and treatment planning and direct linkage to ongoing addiction treatment. And this showed in the first month after hospitalization, reduced addiction severity for alcohol and drug use, and also increased the number of days of abstinence. And while we know MOUD reduces death from overdose, does MOUD in the hospital itself specifically reduce death from overdose? And the answer to that is yes. There's a newer study that just came out last year. It's also retrospective, using propensity match controls, but saw a reduction in 90-day all-cause mortality when MOUD was initiated in the hospital. And finally, there's this, I think, kind of lovely idea that as we improve in the hospital setting, not that we don't already do it, but as we work harder at trauma-informed care, at holistic care, comprehensively meeting healthcare needs, thinking about discharge planning. Doing that in the substance use disorder arena actually spreads to our care for other conditions as well. This powerful idea that treatment changes culture. Next slide. So I'll just dive in, give you a couple of cases here. I know this looks long, and so don't read it. I'll just try to tell you the story. Just to illustrate kind of in our own communities, what's happening for patients, but again, also that distress and difficulty that our hospital and ED teams are experiencing. So this is a patient, young for me, woman, 28-year-old female with a history of opioid use disorder, post-traumatic stress disorder, and homelessness. And she came into the ED with an abscess, but she was actually dropped off by a friend who said, she's got this addiction, she needs help, can you help her? The patient did receive IV antibiotics, did not receive medications for opioid use disorder. Instead, it's noted we counseled her on the hazards of drug abuse. And in accordance with hospital policy, threw out her drug paraphernalia, which made her very upset. And she was told to follow up with the PCP. About 4 or 5 months later, she comes back to the same hospital, this time is admitted with cough, pleuritic chest pain, daily use of heroin, which was mostly fentanyl, and had an opacity on her chest x-ray, was not treated for her opioid use disorder, and so left the day after admission and was told again, follow up with your PCP, particularly because you have blood cultures pending. She comes back the next month, this time with pain and swelling of her right arm. Again, in quotes, due to IV drug use for weeks. She had an abscess, which was so severe it needed debridement in the OR. And interestingly, the note said she had been in another hospital 2 days earlier, had a self-directed discharge because she said they were mean, didn't feel good there. So she did at this hospitalization complete the debridement, but again was not started on medications, left the hospital, and was seen a week later on the street. She's homeless by a street medicine provider who started and continued her wound care and then initiated buprenorphine naloxone for her opioid use disorder. 2 months later, she's back in the hospital, this time with bacteremia and sepsis, and she was on Suboxone at this time, and the patient and her mother really advocated for it to be maintained while she was in the hospital. And the treating team said, well, we can't find evidence that you're on it, so we can't continue it. And so 5 days passed. Finally, the mother goes to the outpatient provider, gets the prescription, like the prescription, fills it, brings the bottle of Suboxone to the hospital team and says, here it is, can you at least give her this medicine? And that finally precipitated it being prescribed to her inpatient. But throughout the hospitalization, it's noted that she was red flagged as somebody with addiction, that she needed to have restricted visitors and limited mobility. So it's a long story, but I thought it was worth giving you the details because it really notes multiple admissions with really no attention to treating her opioid use disorder, leading to many self-directed discharges, significant morbidity, potential mortality, and kind of that diminished trust that can happen between a team and the patient and their family when her Suboxone was not continued. And then also, I think the distress and discomfort for the patient and her mother, but also for the hospital team as well, with these red flags and restrictions that are put on people that can be difficult to maintain. Okay, next, give you 2 more quick cases that kind of illustrate highlight other features of where the guidelines can be useful. So this is a slightly older woman, older than our last patient, 52-year-old, also with post-traumatic stress disorder and bipolar, who was admitted with MRSA bacteremia and an abscess in her pelvis. And the admitting team did a wonderful job, initiated her on buprenorphine, and this was coordinated with her outpatient provider on discharge. But she came back a month later, this time with a septic hip, which needed to be replaced. Again, the team worked really hard, continued her Suboxone during her hospitalization, really worked on her pain management, saying she's got a risk of recurrence of use on discharge if we don't manage her pain well. But then it kind of broke down at the discharge plan. She went home, but her home was 2 hours away from her outpatient provider because of her recent hip surgery. Had pretty limited mobility, and her outpatient provider wasn't aware of her discharge. Once the outpatient provider was aware, they coordinated with the surgeon who said, for pain management, who said, here's some pain meds, but it's not really going to touch her pain, kind of feeling uncomfortable about pain management. And then just a really difficult ensuing several weeks where the outpatient team is trying to manage her pain and addiction remotely, very limited by internet connectivity, and then a home health nurse who didn't fully understand the care plan and was advising the patient that maybe she shouldn't be on the Suboxone because it was interfering with her pain medication. So again, this is one where lots of opportunities to improve on discharge planning in terms of coordination with the outpatient provider, adequate pain management, and good coordination with the home health team. And then one last case, one that we see not infrequently. You can go to the next slide. Thanks, Lorena. So this is an older gentleman than our last two, 79 years old, had been stable on Suboxone for many years for OUD related to prescription opioids, but gets admitted to the hospital with a hip fracture. And it was found that they thought we can't discharge him to a skilled nursing facility on Suboxone. So it was stopped in the hospital. And he goes to the nursing facility on oxycodone and was seen there by the the SNF provider, who found him to be in acute withdrawal and restarted his Suboxone. He then goes home. He was bored, he was depressed, he started to drink heavily, then had a stroke in early this year, again admitted to the hospital. And again, same rationale, his Suboxone was stopped. It was said, well, we can't get him into a nursing home if he's on this Suboxone. And it was also noted, his real problem right now is his alcohol use, and he probably doesn't need the Suboxone anyway, though he wasn't offered medications for alcohol use disorder. So same thing, he goes back to the SNF, he's in acute withdrawal, but this time didn't want to start his Suboxone again because he said that doctor in the hospital said, I don't really need it. Eventually, the attending provider was able to convince him to get back on his Suboxone. But again, the couple key takeaway points here, that his medication for opioid use disorder was stopped twice with the presumption that he wouldn't be able to get into a skilled nursing facility if he was on it, and probably some misinformation, misdiagnosis from the hospital team, which really translated to confusion for the patient. So I give you all of that again, not to be judgmental or condemning, but just to highlight the difficulty of experiences for our patients, but also for our hospital teams. And why we wanted to be able to provide these guidelines to you. So I will stop there. Thank you, and turn it over to Alane.
Awesome. Rachel, thank you so much. So if we can move to the next slide, please. So Rachel did a beautiful job outlining really the excellent literature that's out there supporting the use of MOUD in hospital settings, to include both the inpatient unit and the emergency department, and really beautifully captures in her cases really the why this needs to be done. So as Gordon mentioned at the start, I have the privilege of co-chairing the Maine Opioid Response Clinical Advisory Committee. So we have been working for 4 years on a variety of different efforts. And one of the things that I'm really proud of is some of the documents that we've put out, really emphasizing the standard of care and really trying to support clinicians on the ground with sort of best practices as they're working with patients with substance use disorders. So we are about 40 plus clinicians from across the state, rural areas, urban areas, experiences inpatient, outpatient, harm reduction folks, pharmacists, so just a wide variety of experiences. And so we have these very rich conversations about all issues related to substance use disorder. And I think what really sat with a lot of us was, as we see the number of overdoses climb, it gets discouraging. You feel like, what can we do? And I think what really sat with a lot of us was the statistic that close to 1 in 5 patients who went on to die of an opioid overdose had contact with the hospital system in either the inpatient unit or the emergency department 30 days prior to death. And this is a real opportunity to connect people to resources, to get them started in treatment. And a lot of folks reach a place when they're on the inpatient unit, like, okay, my disease process is really bad right now and really want to get better. And really thinking of it as, in the way that if you have a patient that's inpatient with a, severe ulcer from the complications from their diabetes, a skin ulcer, the idea that we would take care of the skin ulcer, but not take care of the diabetes, or the idea that you'd have a patient on the inpatient unit with a severe exacerbation of their depression, and that somehow we just wouldn't treat that, just didn't sit with us well. So we really wanted to see what was out there on this issue. I spent a lot of time reviewing the literature. There's some very nice documents that we reference, specifically from the American College of Emergency Physicians, really advocating that this is the standard of care. And then a beautiful consensus document written in the Journal of Hospital Medicine that beautifully lays out kind of all the various different options for doing this, why this needs to be done. And they received a tremendous amount of feedback from across the nation just on ways in which it could be done effectively, successfully. And we actually had the opportunity to talk to some of the folks that wrote that paper. So we interviewed national experts on this topic, and it was really a wonderful experience to just hear from them. And absolutely, this is not yet the standard. It is the standard of care, not yet necessarily done across the country, but it is absolutely the standard of care. So we did write this guidance document that is available on the GoPIF website, and we encourage folks to read it because it is there. Next slide, please. So we felt really strongly that all Maine hospitals should provide at least a basic level of care for all patients with opioid use disorder. And we went on to delineate what that means in our mind. We also recognize that there's going to be some hospitals out there that can provide a more advanced level of care, so that they may have more resources, larger group of folks working on the project, so they may be able to provide that more advanced level of care. But we really wanted any patient with an opioid use disorder who entered any hospital in the state of Maine to be able to access treatment, whether they're inpatient or in the emergency department. I think the other really important part of this document that we reference is that we spent a lot of time going through the available resources that are out there nationally. So we wanted to make this as easy as possible for folks to implement. So, if you're looking for, okay, what's the latest and greatest on starting buprenorphine? What's the latest initiation protocols? We provided links there. What about this whole legality question about methadone? We also provided a lot of information there. So we really wanted to make this as simple as possible so people could, take their questions and really build order sets and things like that using these references that are in the tool. I think the other thing that we felt was important was really thinking about policy recommendations. So what are some of the things that the state could consider doing to incentivize or encourage folks to do this work? So there's a section on policy recommendations as well. Next slide, please. So in thinking about the basic level of care, what are some of the critical components? And I think one of the things that always rises to the top is that, we really need to continue training and education about substance use disorders and stigma for all members of staff. I think it's hard still. I was literally on a phone call with a provider at a different setting right before I came in this room because I'm seeing patients today, and just talking about one of my patients that she was caring for and her dirty urines, which was inappropriate to use that term, and that my patient was drug seeking, and all those things that you think people aren't saying anymore, but they're still saying. So it's just so important to educate. My patient is having an exacerbation of her chronic disease, and that is expected. So really framing it up like that, as opposed to somehow she's doing bad things. And so it still is something that we need to deal with all the time from an educational perspective. So we also wanted hospitals to be able to identify high-risk individuals, both inpatient and ED. So that would include patients who are opioid intoxicated, post-overdose, or in opioid withdrawal. So those are folks that absolutely need to be screened and treated. Sometimes substance use disorders do present as a pain that's unusually difficult to manage. So that may be a conversation that could be initiated if there are some pain issues that are having a hard time getting control of. Certainly if there's SUD-related complications, such as the cases that Rachel described, so complications of a substance use disorder that might include infections of heart valves or bone infections or sepsis. So those folks, again, we want to treat the underlying cause, not just the complication of the disease. And certainly any patient who requests treatment of a substance use disorder, again, the idea that somehow patients would be in and say, I need help with this chronic condition and not be able to access it, it's just really important that we have those resources available for patients. It's important that we have toxicology screening that's consistent with substances seen in the community. Now, certainly that is always changing. So that is something that will be updated sort of regularly, but I'm still aware of some tests that can be ordered that don't include fentanyl, or hospitals that don't have fentanyl on their standard screen. And so, we don't see really the traditional heroin anymore in terms of from the poppy plant. We see almost exclusively fentanyl and fentanyl analogs. So if you're not able to see that fentanyl is in someone's system, it's not particularly helpful. So it's really important that the toxicology testing is accurate for what we're seeing in the community. And then provider knowledge on how to interpret findings. I mean, that's really important. I think, it's not always as simple. Sometimes it is, sometimes it isn't, but there's a lot of great resources out there. I recorded a didactic for the Maine SUD Learning Collaborative on this topic. And so there's lots of educational opportunities to be able to sort of enhance your ability to interpret toxicology screening. Next slide, please. So another element of the basic level of care would include having buprenorphine available on the hospital formulary. So super important that the medication is there when it's ordered. And we really want folks to get to a place where buprenorphine is available in both the emergency department and in the inpatient hospital setting. Just again, super important. And I think one of the things we used to hear a lot was this, when an X waiver was required, so you used to have the special license to prescribe buprenorphine, in terms of sending it to a pharmacy and as a prescription. That, as of about 3 months ago, is no longer required. So any provider who can write for a Schedule III controlled substance can write for buprenorphine in terms of sending it to a pharmacy, and it will be filled. So that was one of the more common reasons we hear, well, we don't have providers with X waivers. And now that requirement has gone away, the ability to start someone in treatment in whatever setting, whether it's the emergency department or the inpatient unit, then you can send a prescription to potentially bridge them to that next appointment. It also allows more creative initiations into treatment. So if you had a patient who was in the emergency department, they were seeking treatment for their opiate use disorder, but they were not in withdrawal, or you couldn't initiate them while they were in the setting, you can send a prescription home. And there's a wonderful toolkit, again, linked in the guidance document that we wrote from the Maine Medical Association Center for Quality Improvement, where there's an at-home induction or initiation protocol that patients can literally take with them and go. So again, lots of different options to be able to access this medication and to just have this available for patients. We also feel that all hospitals should provide evidence-based best practices for treating patients on MOUD, which certainly includes not ever stopping the MOUD unless there's a really clear clinical indication to do so. And that's rare. It's certainly not impossible. I was trying to think of a situation when we had done that, and we had a situation where a patient who was on buprenorphine was diagnosed with metastatic lung cancer, and he was transitioning to hospice, and there was a lot of conversation about needing to manage his pain with a full agonist opioid, and that at that time he came off the buprenorphine. So there are times when that happens, but it should be very, very rare and very clearly documented in the chart, and certainly very much consented with the patient. I mean, obviously that was a conversation that we had with the patient in terms of his goals and how he felt and where he wanted to be. So certainly it's not something that should just be done abruptly without patient consent really ever. So we want pain management that's sensitive to the unique needs of patients with substance use disorders. The one really nice thing is that this clinical advisory committee has tackled a lot of these complicated topics already. So on the GoPIP webpage, there is a really nice document that's there that describes kind of best practices for caring for patients who are on MOUD for their pain. There's a lot of very safe modalities to use and creative ways to make sure that patients' pain is managed. And just all the issues that making sure you're inquiring about pain, not assuming that the MOUD manages the pain. So there's a really nice document there. We want a direct linkage to buprenorphine prescriber at hospital discharge, including a scheduled appointment. You know, there's a lot more resources available every year. There are more and more treatment resources available. I think, again, one of the upsides of COVID, not that there were many, but there was really an expansion of available telehealth. So that certainly helped us, particularly in rural areas, which is one of the other settings I practice in. So patients can, you know, get on a screen with a provider that might be 3 hours away by car, but they can provide that care by a telehealth model or counseling via telehealth. So there's a lot more options available for patients if they have transportation, you know, limitations or other things. We also want referrals to post-acute care facilities or skilled facilities that provide ongoing treatment with MOUD. That's super, super important. Amelia Hersey has done some amazing work on that across the state and, you know, has a lot of great protocols. So again, that can be done. But we shouldn't not, you know, we need patients who are started on MOUD in the inpatient unit to be able to go to a skilled facility if that's what they need. And certainly that has been an issue previously. And we want naloxone kits in hand at discharge. I think so important. You know, prescriptions are great too, but I think, you know, certainly those of us that are on the ground are seeing, because of the potency of fentanyl, sometimes it's multiple, you know, 6, 7, 8 doses of naloxone that's required. So just giving kits out, I think, is just really important so folks have it available to them in the home. And then we would love to have wraparound services for individuals with OUD. I love the idea of peer support. I think it's one of the most important parts of the program that I work in. So that referring patients to somebody with lived experience who, you know, models recovery and really can help advocate for that patient is just such a tremendous thing to be able to see. And so that's an important component. And, you know, harm reduction plays an important component too. So, you know, if you have a patient that, you know, is you know, moving on the road to recovery, but maybe not, you know, fully able to engage yet, you know, harm reduction is critically important. So getting them connected to a syringe exchange program or other resources, because again, that can be a road into MOUD treatment if and when they're ready for that, but making sure that they have the resources that they need to stay as safe as possible with their substance use disorder. Next slide, please. So we're hoping that some hospitals will be able to provide an advanced level of care. So we want, again, every patient who goes into an inpatient or ED setting in the state to be able to get the basic level of care. But there is an advanced level of care as well. So that would be the basic level of care plus a commitment to educate learners and providers in training about the full spectrum of substance use disorder care. That has absolutely been one of the greatest joys of my career, is training the next generation of folks who are going out there and just really normalizing that this is just like any other chronic disease that you're going to see. And I think it just has made it so much easier for folks as they go out into practice to do the work, because I think historically people weren't really trained and it didn't really know what to do. So making sure that we're training learners. We love the idea of protocols and resources to utilize extended release buprenorphine in the emergency department inpatient setting. So extended release buprenorphine works beautifully. Patients really like it. And in particular, you know, high risk patients who might be going out into a high risk situation, maybe are unhoused and you're trying to get them connected to resources. It can be so important to just get that medication on board so that they don't need to worry about picking up a prescription or keeping a prescription safe. So it can be a great option for a lot of folks. Integrated inpatient care management, peer support, and then initiation of MOUD using methadone in the inpatient setting. So I think that is a more complicated for sure in terms of the logistics of it, because it requires really starting that discharge planning the day the patient is started on methadone, making sure that you have an outpatient treatment program to be able to refer patients to. The actual starting of the medication is oftentimes not that difficult because it's a full agonist. So if you have other pain medications on board, it can be actually simpler to start. But you cannot prescribe like a bridge prescription like you can with buprenorphine. So it's just a little more logistically challenging. So that's why it's probably more of an advanced level of care, but an important level of care for sure. Next slide, please. So again, one of the we want to dispel some of the common concerns that we hear. I think still I hear a lot, it's illegal to provide MOUD in the hospital, especially methadone. We've talked about, certainly buprenorphine could always be started on the inpatient unit. It only required that X waiver to write the prescription at discharge. And again, that X waiver is not required anymore. I think the methadone piece is very confusing for folks. And so we provided all the links to, the legislation or regulation, I'm not sure what the right word is, but in our documents, so if you have questions or somebody in your hospital has a question about, oh, is this legal? You can kind of get them that information real time so they have it. And again, starting to work with getting them connected with a resource really at the point of initiation. Again, a common concern is that, well, it's dangerous to start MOUD if there's no plan at discharge. And we talked about, really important to start planning very early on, just as you would with any other chronic condition for a plan post-discharge. And again, a lot more availability of low barrier telehealth options than ever before. So that's pretty exciting. Next slide, please. Another common concern is we don't have the clinical expertise, and we certainly appreciate that that is an issue. I think there's a lot of available resources. Again, the links that we provided in the document. There's also, ECHO series. There's the wonderful Maine SUD learning community that has a lot of really great education. And again, in our document, toolkits, order sets, things to really make it as simple as possible to implement this program in your hospital setting. There's other ideas about, building in provider incentives or other things to or quality measures to get folks to do this work. The other thing that we recommended as a potential policy recommendation was supporting a kind of a warm consult on call, sort of phone a friend type thing, where if a patient if a provider is struggling trying to initiate treatment, that they could call someone to ask for help. That's been tremendously successful with the Maine MOUD program, that I'm sort of the on-call expert for that. And, honestly, I don't get called a ton, but I think providers knowing that they can call just makes them feel more confident and willing to sort of do the work. So that's an option potentially. And then, we don't have the staff for an addiction consult team. So there's a really nice paper that we reference. This has taxonomy in the title. And I think there's a lot of different ways this can be done. So it can be done as an inpatient consult team, or it can be done, training your hospitalists, or, there's a lot of different ways it can be done. And you could even start one way and then transition to another. So it doesn't have to be an inpatient consult team at all. It certainly could be the hospitalist team after more education. Next slide, please. Some people say, well, not a clear return on investment. I think that these are just things to consider. So there's, I think this is absolutely a billable service. I certainly, when I do inpatient consults or was doing inpatient consults at Maine General, we absolutely billed under the standard consult service model. But it's just quality of care and good care. And we've already established that it really reduces complications. So you have fewer kind of bounce back patients and, just improves outcomes certainly down the road. Some people say, well, it's just too hard to do on my own. I want to do this, but it's too hard. And I think we absolutely agree. And there's definitely a momentum across the state that this is something that needs the support of the healthcare system. So it can't really just be one person on the ground. It needs the time, the effort, the infrastructure, so that providers can be trained appropriately, get the resources and skills that they need, get the systems in place in terms of order sets and things like that. And again, I already talked about quality measures. And then there's ways in which in other states that some of the larger hospitals have built up capacity first and then kind of serve as consultants, liaisons. Again, I think there would be models potentially where you could have, the consults of the specialists come in via telehealth or something like that. I think there's creative ways in which this can be done quite effectively with really the expansion of the telehealth model. Next slide, please. So, this is where kind of getting the document out there, encouraging folks to provide feedback. There, again, reference the Maine SUD learning community, lots of good resources there. Next slide. We put in a slide with our email contacts information for questions, for follow-up, and I think we wanted to be sure to leave some time for questions. So I think that was my last slide. There's a couple I think there's just a few more which have references on them. Yeah, perfect. So that's the last official slide. And thanks so much for your attention. We really appreciate it.
Thank you, Alane and Rachel, for that presentation. We have one question, and then I'll follow it up with some questions. But one of our listeners is asking why are there not enough clinicians for an addiction response team? I'm sure you're both anxious to take on that one. So what are some of the reasons that you think that we don't have enough clinicians for these teams?
Do you want to take? So I'm not totally sure I understood the question, but I think and maybe I missed part of it, sorry. I don't know that I think what we're talking about is that there's lots of different models that could be created. And so don't necessarily have to create a whole new team of clinicians to be able to provide this service on the inpatient unit. It could be training up existing clinicians. In some settings, certainly here at Maine Med, we have a service that does that just because of the size of the institution, but that's not going to work necessarily in other settings. When I was at Maine General, we were a 3-person service, and we took, 1 week at a time, and generally saw 1 to 2 patients a week. So it really depends on the setting that you're in. Lots of different models. I don't know, Rachel, if you had any thoughts on that.
And I think the idea being that it's a both and, you can have a model where it's, 1 or 2 clinicians who are trained to do this work and can, prescribe medications and maybe help with pain management. Both and there are opportunities for whole teams where you have peer support and a social worker and a pharmacist and a nurse. And again, one of the articles in the references can talk about sort of what the advantages and disadvantages of both are, but I think not to feel like, in fact, Lisa Letourneau cautioned us about this early on, not to feel like you have to have all of the bells and whistles to do this work well and effectively. Because to your point, yes, it's having an addictions counselor and peer and social worker and nurse and everything on one team can be a burden both to hire and to subsidize in the early stages.
Yeah, the listener has clarified that she's really asking about on-call support, what those resources are. I want to ask a couple others with respect to the sharing this presentation. All these webinars are recorded and are on the AdCare website. So maybe Lorena or Madison could put in the question and answer. I think we've disabled the chat perhaps, but I'll let you know where precisely. It does take a few days usually before the recording's available, but anybody that misses this, and if you want to share with your colleagues, because we'd love to have you do that. So they are all of them are archived and they're all free and they're all available on our page on the AdCare website. One listener said, will rehabilitation be able to start, will rehabilitation facilities be able to start pain patients on these medications?
So again, Alane referenced a really talented clinician named Amelia Hersey, who I have the privilege of working with at Penobscot Community Healthcare, who has, to my knowledge, there is not, I think, similar to hospitals, skilled nursing facilities have just not fully picked up the mantle of prescribing these medications. There isn't any legal or regulatory barrier. Often the barrier is, to the earlier question, what's the support to do so? So again, there's, I believe, a separate clinical guidance document on this, which provides toolkits, provides resources for those facilities to be able to do it. And for Amelia, no good deed goes unpunished, but she actually does a lot of talks and in-services to support this work so that the situation like the case I provided doesn't need to recur, where the buprenorphine, if it's initiated in the hospital, can certainly be continued when someone's in a skilled facility.
The one listener has made a comment that, not a question, but about the scenario where with the difficulty with the discharge plan and how important it is to look at the social barriers that may be present for the hospital team to be aware of, that you know, the patient may have difficulty being able to follow up with treatment in the community. And our great friend and colleague Eva Quirian has made a comment that starting these services really begins with a buy-in from the hospital itself, that where there's a will, there's a way, and the hospitals are already managing chronic diseases, and Eva's stating correctly, there's no reason why we can't manage opioid use disorder as we manage other chronic diseases. There is another question here. Thanks for the active questions. There's been conversation about creating a deflection peer support for these type of issues. Having the funds for an organization have supports placed around the rural areas, be able to go into the hospitals and courtrooms to help when people are at the point of change, being educated with the resources available, including the ARMS system. I'm not sure I know that reference. This is a huge need to decrease the revolving door when it comes to SUD and co-occurring disorders. There are some models. There will be more. For instance, when you talk about the courthouses, there's a pilot in Washington County where there's a navigator at both the courthouses, attends every arraignment, is introduced by the judge, so that anybody in that courthouse who is being arraigned that day that has a substance use issue and needs to talk to somebody about housing, about a lawyer, about a legal need, about a clinical need. We have a person with lived experience working full-time in that county as an additional resource to those individuals, in addition to our options liaisons, which we're about to double from 16 to 20 to 32. So I agree we need these individuals who have made a decision to seek recovery need so much support, and we are trying to put those supports in place. And of course, we also need beds, and we are trying to get as many beds online as well. Okay, let's see. Here's another one. How will the state collaborate with hospitals to address the emergency response beds? Currently, the capacity issues currently causing many issues related to SUD and mental illness in the emergency departments. There's not enough beds or staff to address these ongoing concerns. How will the state collaborate with the staff and support by providing, the state will collaborate by providing additional resources, by, again, one example is the living room in Portland. We need more of those mental health / SUD crisis facilities. But absolutely, we want people treated in the appropriate setting, and we realize that there aren't enough. There's not enough facilities, nor is there enough staff in some of the facilities to handle the demand, and we are working on it. And do either Rachel or Alane want to address that issue of capacity and demand and some of the things we're doing to meet that demand?
I was thinking as you were talking, I mean, so many opportunities, I think, and so much progress being made. And I think just in thinking about it, is there's overcrowding, just opportunities to sort of treat so that people are coming back multiple different times. And I think, encouraging the hospitals that are on today, or providers, or anyone who's listening, to think about what could we do to best support you as you're working with these patients, and does it make sense to have some type of technical assistance program like the Maine Medical Association Center for Quality Improvement does with the emergency department. So providing kind of a toolkit, coming in and helping support and educate, or is the sort of on-call 24 hours, provider that needs to be available. Like I know I would be absolutely willing to take that call, as would many of my colleagues, be willing to be part of a call service if that feels like that would be a more effective way to implement this. So I think the state is open to hearing about concerns, questions about ways to best implement this. And we're here to support you in any way that we can.
Yeah, I think the last thing we'll comment on is one of our options liaisons, Nick St. Louis up in Hancock County, has raised the issue of why options liaisons, whether they should be included on the hospital response teams. And then another listener said, should options liaisons be mentioned as a bridge to resources? Absolutely, along with recovery coaches. We are supporting, the state's supporting recovery coaches available to 8 emergency rooms. That's soon to move to 10. We absolutely would love to have recovery coaches available in 24/7 in all 33 emergency departments, recognizing that a person that might be willing to talk to a peer, talk to a person who's been right where that individual is now, rather than to an emergency room nurse or physician. So that would be the goal. We already have made the commitment and are implementing the increase in our options liaisons. And most of you are familiar with what their scope of work is 1 in each county, and there's going to be 16 more who will be deployed strategically in certain counties. So recovery coaches in the emergency departments, options liaisons in the community, court navigators in the courtroom. We're going to try to do all of this. And now we have some resources from the settlements to do that. So it's 12:31. I want to absolutely thank Alane and her subcommittee and the clinical advisory committee that put these documents together. I want to thank Alane for her talk this morning, and Rachel, thank you for coming back from Portland, Oregon to give us the advantage of your experiencing working with people experiencing homelessness. And thank to all of you who are so loyal to our work and attending these webinars. We will see you on